that is initial innovation, how it came up, and since I was working with Professor Aaron Riviere, so I have more of privilege to speak on this, or rather my pleasure to speak on this topic. So this is a new topic, and for the physicians who are sitting here, it is a non-surgically, not replacing but implanting a valve in a patient of aortic stenosis. Aortic stenosis is emerging as a very important disease, especially with the aging population, especially in degenerative aortic valve disease. So 20 years of TAVI, a vision by the pioneering team. I worked with Aaron Riviere during 1996 to 98. And at that time, it was only a concept. And the first TAVI was done in 2002. So I was here, but I was present here during the time when it was first done. So I have my pleasure and privilege to speak about Dr. Aaron Riviere, who is the father of TAVI. And he is a well-known figure, and short of Nobel Prize, he received all the prizes. He is Dr. Riviere. He was working with Respicon. He was my head of department when I was working as a fellow in interventional cardiology in the same paid by the French government. So this is how the innovation came from his mind. And at that time, I still remember, he was driving a car, I was sitting, he said he has a project in mind. And the project was non-surgically implanting a valve. I was completely taken aback. I said, how it will do it? He said it will come up soon. This was a team, Dr. Bala, Dr. Riviere, Elaine Alshaina, Brune Koenig, Geneva, Christoph Prof, Nadir Saudi, Frederick, they were all colleagues when I was working with them. Because this was a time when the things were being in the progress. And this is how we maintain further relationship. This is my son Chinmay. Dr. Riviere is cycling him. In 1996, he's sitting here right in front of me now as a doctor. He came to my house in Sarita Vihar in Delhi. And this is the photograph that time. This is during one of the ESC meetings. And this is how I was working as a fellow in 1996, 97. Dr. Riviere here, this is the cath lab of Rouen, Charles-Nicole, where the first procedure was done. This is one of the restaurant with my wife in 1997. So a long time, ISK was there for 1996. This is a case when we took the first case from India, 2011. We did a case of TAVI, patient flying from here, one of the very senior industrialists, and he lived for 10 years further, and he died recently because of kidney failure. So that was the time, this is November 2011. So coming back to the topic, the plan of presentation will be scope of problem of degenerative aortic stenosis, balloon valve valvoplasty, development of non-surgical aortic valve, FIM, and then I'll show the case report. So degenerative aortic valve stenosis is the most common acquired valvular disease in adults. 26% of the population above the age of 65 have mild, moderate to severe aortic stenosis. 2% are symptomatic and should require treatment. It is estimated that within 15 years, the number of AS patients will nearly double. So surgical valve implantation should be performed promptly once even minor symptom occurs, and prognosis of aortic stenosis not significantly changed since 1960. In the elderly population, the prognosis is even worse. 30% patients will die within 3 months in patients who are waiting for TAVI or surgical aortic valve replacement. 30%. So this is the important emergency, not the urgent treatment which is required. In standard care of patient, mortality after IVR is 2.5%, but with the comorbidity, bypass surgery, combined risk factors, mortality, kidney failure, difference ejection fraction, the mortality goes up. But at the same time, after successful valve replacement, patient lifespan returns to that of general population. Coming to the first step before TAVI, which was 1985. Dr. Riviere himself did the first aortic balloon valvoplasty, and at that time, the aortic valve replacement was almost contraindicated because it was considered to be very high risk. And this was a 72-year-old woman who was highly symptomatic, and there was a memorable reaction to the world community because it was the first time aortic balloon valvoplasty was performed, and it was published in Lancet in January 11, 1986. So this was history, but there was especially balloon which was created by the name of Riviere-Lattac balloon catheter, and this was done. In the 90s, thousands of cases were performed worldwide, impressive number of registries, but there was a major limitation, early valvular stenosis, and no beneficial effect on the long-term mortality. Solving these issues became a personal obsession for Dr. Aaron Riviere, and therefore he was thinking of transcatheter heart valve. During TAVI, VAV has become a simpler and safer percutaneous technique and still required. Now we have to do with a per close technique, local anesthesia, rapid ventral pacing. This is very important during the time of balloon inflation. So this was the Rouen 1985, the first case which I was talking about, and early stenosis was there. What to do next? So what to do next? Because the aortic valve, balloon inflation, the aortic valve does not last long. 30 years later, BAV is not there. Balloon angioplasty is still required in the patient before you do the TAVI, because you have to make a space across the aortic valve to do this. So it's still important. Coming to the second part, development of non-surgical aortic valve and FIM. Since 1985, development of innovative technology in the field of valvular disease was done. And from 1985 to the first case in 2002, there was a big gap of 23 years when it was developed. According to Edwin Land, don't take a project unless it is manifestly important, nearly impossible. What I want to highlight here during this talk of next 15 minutes is the importance of innovation. You see, a lot of people are doing in India now, but not many people do not know how many gallons of waters have passed through the Ganges or air before the things came up from 1985 to 2002 when the first case was done. So this is actually really important to know. And single goal was to provide a life-saving therapeutic option for patients with asymptomatic AS and decline for surgical valve replacement at that time. Now it was low surgical risk as well. So the goal was to develop implanting a valve prosthesis. This is the hypothesis. Implanting a valve prosthesis within a diseased calcific aortic valve on a beating heart using percutaneous catheter-based technique. And of course, you have to improve there should not be no restenosis. It was highly challenging because of the valvular calcification, the surrounding structure, coronary arteries, mitral valve, IV septum, and major clinical issue while thinking of doing this project was coronary occlusion, mitral valve injury, permanent AV block, stroke, AR, process migration, and non-lasting results. These were the challenges which were thought of at that time. The birth of the concept of Stenting valve came up in aortic stenosis. A balloon expandable stent, the hypothesis was a balloon expandable stent with highly radial force might keep the valve open. A balloon expandable stent with high radial force might keep the valve open. A valvular structure would have to be attached within the stent. A valve has to be attached within the stent, and this was the use of a challenging combination of balloon expandable frame and valve structure. You have to have a combination of balloon expandable frame and the valve structure. This is how you can put the valve. So implanting a valve processor within a disease aortic valve structure, I told you this was a challenge. This was 1994. This was idea to validation of concept. I was working in 1996. It was still in the process of being in the project. Could a balloon expandable stent can be used to maintain the valve open? And this was 1994 with 16 fresh specimens of calcific AS. And this is how Renu Barmani confirmed circular stent opening in all. Renu Barmani from Washington DC confirmed that this is possible in autopsy studies, especially in animals. And of course, you can put a valve here with respect of adjoining structure. This was the hypothesis, and they have worked very hard in the animals to confirm whether this is technically possible or not. So, 1994, figuring the stenting valve and the procedure of TAVI. This is how it was. This was planned. Crimping diameter 8 mm transfemoral approach was conceivable, and these are few earlier pictures. From 1994, when the concept was almost finalized, till 1999 they were looking for a sponsor, because for any innovation you need a sponsor for the companies. And what were the comments from the experts? Comments from the experts from all biomedical companies, including Medtronic and Edwards. Dr. Krieger and his team had sent an email to all these companies to sponsor the project. And they said the comment of the expert was totally unrealistic, definitely impossible. 1999. Major technical issue, unavoidable life-threatening complication, most stupid project ever heard, just forget it. This was the comment of the experts in 1999, and the comment included Edwards, which is selling the maximum number of valves now, and also Medtronic, which is selling the core valve and the self-expanding. These companies had rejected the idea, saying that most stupid project ever heard, just forget it. End of the story. 1999, Dr. Krieger was rejected. What to do? Then they submitted to this is a forget it, and then they found a company with Martin Leon. 1999 foundation of PVT, and this was still initial starting, and they started extensive laboratory testing, animal programs, sheep model, acute electronic studies, and the bi-reflex bovine board was educated. Project was still alive in 1999 when they formed a company by the name of PVT. You can see Martin Leon, Alain Crivier, and the other two people from the industry, PVT company, and that was the private company they signed, and this was actually signed agreement in Israel. Investment development, this is a photograph of that time. And they requested engineers a procedure with a highly resistant frame, containing uni or bi or tri-different valvular structure, able to homogeneously compress, and of course enlarge by balloon inflation. These were the hypotheses. They told to the engineer that we want to produce this valve. And this was actually done, and safety, durability, hemodynamics was done, and they made it. And this was the first valve that was made by the engineers. Tri-leaflet valve, polymer thin mobile bicardium, stainless steel stent, single diameter, and 24 French pyramid size. You need a 24 size sheet, and these are all the technical frame size and all those things which were required at that time. So it was fairly simple anatomy. But what was the deficiency in animal model? No, there is no aortic valve calcification, no aortic valve degeneration, and different arch anatomy. This was actually an animal model. This was moving to human was the most difficult decision to make, because now you have a different animal model. We have tested, but moving to humans was different. Eventful day by April 16, 2002, the date a patient who had actually, this was April 16, 2002, and I still remember Dr. Peter saying that he spoke to that as a patient of 57-year-old cardiologist shock, should we do it? Martin Leon, he spoke to Martin Leon on phone. He said, please go ahead. Then it was EF 12%, multiple comorbidities. That is the first case. Intraventricular thrombus, aortobicular bypass excluded, no funeral, turned down by 3 surgical teams for the AVR. Failed emergent transseptal BAV, back in shock in 24 hours. Challenging decision of transseptal TAVI as a life-saving procedure. That was first case we're talking about. All current contraindication of TAVI was there. And then finally they did it successfully despite all the odds. And this was transseptal approach in the patient, and patient lived for quite some time after that. So this is the feasibility of TAVI was established. No migration, no occlusion, no MR, no AV block, only mild AR, and optimal valvular function. This was the feasibility which was established at that time. So from the dream to reality, in 2002, the first case was performed. All these pictures are there, you can see, and you can see the eyes of this, and first ever seen TSVL CT confirmation of RFA finding. From 2002 to 2005, it was 2002, almost 20 years. Dr. Kibir is celebrating 20 years of TAVI very soon. To 2002 to 2005, a heroic period in Rouen, 40 patients were done, I revive and recast trial, compassionate, these are patients who were compassionate patients, imminent death, very high risk for surgery, they were taken. And they demonstrated the potential benefit of disruptive technology on such a critical patients with life-threatening comorbidities. This was done, and this was pneumatic balloon training was done inside the lab, of course, being done still. And then this was 35 cases were done, 33. Transseptal approach in 33, and transfemoral retrograde was also there at that same time in 7 patients. And then, of course, a few patients of heroic period I want to show. 83-year-old lady who was 1 year post-TAVR. This was during the heroic period, and then she's playing this. And this was 6.5 years. She did for 6.5 years, 2010. And then another patient who was actually retrograde done, Rouen patient 10 film plan retrograde TAVI was there at that time. So these were the heroic period 2002 to 2005, and then the flight. Transseptal takes a flight to the world. It was still in Rouen only. At that time, then of course, Dr. Martin Leon started doing, Antonio Colombo from Milano, Patrick Serral from there, and Dr. John Webb from Canada. All these people started doing it, and in 2005, 100 TAVI was confirmed. Only 100, but of course, it's still 100. That was century which was made in 2005. 2004, it's the same company, Edwards, which had refused the idea. Now it acquires PVT, which was the founder company which had given the birth of TAVI. So now the valve is known as Crevier Edward valve. At that time, 23 millimeter size, required pericardium, sheath of 24 French, mainly plastic. This was later converted to Edward Sapien, and then of course transfemoral approach. It was introduced by John Webb, who did a study that transfemoral approach, retrograde approach, and the new sheath was introduced by the name of Retroflex. And from 2006 to 2009, many European registries and pivotal partner US trial was started in 2009. So Retroflex sheath came up as a very important technological advancement, because then it was over. At the same time, some few people started doing from the transapical sports approach that they were inside the operating group. The surgeon wanted to do from the transapical surgically, opening through the going to the LV apex, and this was initially done, but for some reason now it is not being used at all. Now at the same time, Edward valve is a balloon expander valve, while the self-expanding core valve also started developing, and launch of the concurrent device, which is now being taken over by Medtronic company, Albert Grube, J.C. Labordo, Jacko Swing, all these people were actually pioneers in developing this new technology of self-expanding valve. So why at this stage nobody could have predicted the incredible success of fast expansion of TAVI? More than 15 lakhs procedures have been done till today all over the world. So what was the reason? I will give few slides. what was the reason why the slides have, why the success has been so fast. So improved devices, technological skill, based on echo, multi-slide CT scan and new imaging technologies thanks to the constant support of the companies, vascular approach, anatomy and valve sizing, then of course decreasing sheath size, additional valve sizes, improved sealing, positioning, and of course from 2005, Edward Sapien changed to Edward Sapien XT, and from 2012 is Sapien 3 from the Edwards. And on the other side, the core valve is now evolved at the same time. So those technological advances have been great. Emergence of firework for many new devices, many companies have come up. This is the reason for the other success, other reason for success. Then of course the transfemoral approach is a default strategy now, more than 92% transfemoral approach, which is going to the femoral artery, is a default strategy in 92% of cases. The transfemoral approach makes the process simpler, faster and safer, increasing number of potential candidates in TAVI. And then of course with Sapien 3 TAVI is turning into stent-like procedure. It's almost like a coronary stent-like procedure, and with the launch of Sapien 3, this is like a stent-like procedure. This is another reason for the success. Initially fiercely opposed to TAVI under local anesthesia sedation, now convinced. Initially, if you remember, that RUA has been doing always under the conscious sedation, local anesthesia, while America has been doing mostly in general anesthesia. So now people are usually convinced that this can be done in the conscious sedation without general anesthesia. And then of course the second important reason for success is large body of scientific evidences, multiple TAVI registries, math history versus surgery, evidence-based trials, and of course as you can see in the 202 came, eye divide, recast, traverse, these are the trials which happened, and RUA, and then of course the US trial, European trial, not details, and then of course finally it was the partner trial which has convincingly got approval of the CE mark and later on the FDA mark which has confirmed this. So Bermuda Triangle study was also there in ESC 2012, and then coming on to the major advancement which has come up is a partner trial which was with the Martin Leon and other team and with Alan Riviere, and they had a partner one which was for immunoglobulin high-risk patient, and this gave a FDA approval in 2012. Then partner 2, intermediate risk patient, 2006 FDA, and partner 3, low risk patient, more than 75 years, and got the FDA approval in 2019 for Sapien 3, and this was Sapien XT, and this was Edward Sapien. So non-inferiority or superiority of TAVI was established with these trials, approved TAVI for the low risk patient, and this was actually apotheosis of TAVI. This is the most important. FDA approved TAVI for the low risk patient, more than 65 years patient. And this is a spectacular improvement. Until now, more than 15 lakhs cases have been done worldwide in more than 70 countries. And this is how, if you can see, the evolution of the first 1985 till FDA approval and then expansion to all the newcomers. So 30 years since BAV and 20 years since first implantation. Extension of TAVR indications are also there. Americans speak TAVR, European mostly speak TAVI. This transcatheter aortic valve replacement is what they say. I personally feel it's not replacing the valve, you are putting another valve. So TAVI is a more technologically correct word rather than TAVR. But Americans always speak TAVR. So valve and valve is coming up, bicuspid valve, asymptomatic AS. So these are the few further newer indications, moderate AS with heart failure. So whether they should do the trials are going on. The breakthrough technology has opened a new world of cardiology by stimulating the transcatheter cases in this world. And I will show you a few slides because of the case. I think I have another 3-4 minutes that I don't see the market. So 1.5 million patients have been treated today worldwide in more than 70 countries. And we would have believed, who would have believed this 20 years ago, a new product, TAVI is conceived for patients who are not candidates for SARM. At 2002 it was said TAVI is conceived for patients who are not candidates for surgical aortic valve replacement. And in 2022, surgical aortic replacement is indicated in patients who are not indicated candidates for TAVI. So this is a paradigm change which has happened in 20 years. So I would like to show you a few more slides of my case presentation. The first case which I did, I think I have to skip 2 slides because I had. And then I told you, like 2011, we did a very important case, the first case from India, which was done actually in France with Professor Riviere. And this was an 84-year-old patient who was refused by surgeon. He had previous bypass surgery, and he had a severe aortic stenosis, valve area 0.7, T given 85, T given 65, ejection fraction well maintained. One of the bypass was already occluded, diabetic, and of course the high creatinine level. Poor malfunction, COPD on many inhalers. So, combination of bad lungs, bad kidneys, previous bypass surgery, and severe aortic stenosis. The surgical consultation led to the conclusion of high risk surgical valve replacement. It was decided to do a TAVI. At that time, the valve was not available in India, so we thought of taking it to France. And the procedure detail was 18 French removal sheet was used. No flex sheet. Edward XT valve was available. Now Edward CT is available, and it was done. And of course, I was also scrubbed in this case. And if you can show some of the slides, the important thing is especially the valve being implanted. This is for the physician because cardiologists might know. I think this is correct. This is how the valve is going up. You have a tail catheter. Then the balloon. This is balloon valve dilatation is being done. I think this is not in the years. Okay, doesn't matter. The valve is going up. As you can see, the valve is going with the monoflex sheet, and this is going up. Now it's crossing the aortic arch, as you can see. And the valve now will be placed very accurately across the aortic valve here. And this is a very important step to have a tight placement, just avoiding the coronary arteries origin. And then, of course, this is inflated. This is inflated valve. And this procedure, as I was clearly remembering, I'm remembering that it was not more than 35 minutes. The sheet was removed. And then, of course, perclose device was used to remove the sheet, and this is how the patient was discharged on the actually 5th day. And 4 years clinical follow-up at that time was okay, but we have 9 years clinical follow-up, we were getting admitted. The last part of the presentation will be a maximalist versus minimalist environment, which means that whether you should do it in general anesthesia, with TE, or you should do only with thoracic and local anesthesia. As the things are there, the people are moving now from maximalist to minimalist environment. Now the procedure has become more simpler, especially for Edward valve. Conscious sedation, local anesthesia, no transcatheter echo, perclose star, 10 minutes duration of procedure 45 minutes, discharge on 3rd day, just like an stent. Now America, for example, if you can see the team America, that was 2009. So many people, including surgeons, general anesthesia, anesthetists, and this was a very hospital Atlanta, USA at that time. But most of the centers in America are also moving to the minimalist environment without general anesthesia. I would like to just introduce when I'm here for physicians, we also do in the European course on revascularization. We have in London, Paris, and from Rome, Zurich. And next course will be in Iceland. In Delhi, it will be on 31st July. And we are planning to do in August 10 to 13 in the University of Iceland. So I hope I'm clear. I wanted to tell you that bedside to bedside, a lot of passion is involved, especially introducing the valve technology, which is not done ever. And a lot of work is involved, animal experimentation, talking to engineers, finding a sponsoring company, and then we are eating the cake here. All over the world, patients are getting treated. Life-saving procedure as of now is actually a life-saving procedure. I told you that this patient was 84-year-old, lived for another 9 years with the same valve. And this is biprosthetic valve. We still know the durability is about 9 to 10 years because it's finally biprosthetic valve. So we have now viable valve also. That means those patients who have already been treated either by surgical aortic valve, biprosthetic, or patients who have done earlier TAVI and they have got now problems, that they can be done easily, but the trials are very limited. Thank you very much for the time and listening to me. And this is how bedside to bedside. Thank you very much.
Thank you, Dr. Vivek. It was a wonderful talk, and you summarized the 20 years.